This is a review on a paper that I've read in Veterinary Ophthalmology. So I looked at a paper by Setanova, Powell, Setanov, Smith and Gould in April 2021. The paper is on melting corneal ulcers, keratomalacia in dogs, a 5-year clinical and microbiological study from 2014 to 2018. So the objective of this study was to evaluate the bacteria found in melting ulcers, looking at which antibiotics those bacteria were sensitive to and how that affected the outcomes in those ulcers. So for me, this looked like a good paper to read because it's something that I commonly come across in my clinical practice. So first of all, I looked at the paper to see how the study was performed. Importantly, it was a retrospective study. So the authors searched the records between 2014 and 2018 for the words keratomalacia, melting corneal ulcer, melting, corneal melt, malaysic, collagenolisis. And basically they looked at all those cases and then they included the cases that had undergone bacterial culture and sensitivity. It was a single centre study done at Davies Veterinary Referrals. I guess importantly for me, I'm UK based, so it's a very similar population to what I look at. I guess the main difference is I'm first opinion practice rather than a referral clinic. But yeah, it's a UK temperate climate. And essentially when they did this, they found 110 melting ulcers qualified for the study, and that was in 106 dogs. So the authors explained how they diagnosed keratomalacia. Ultimately, they basically identified a fluorescein positive ulcer, which from a slit lamp biomicroscopy, they saw a grey-white gelatinous corneal opacity with softening at the margins of the ulcer, and they could see that there was liquefaction of the corneal tissue. And then they used a scoring system in order to assess those ulcers. And so I quite like this because I've not actually come across this much before, although the paper refers to a couple of other papers that talk about scoring systems, and it's perhaps something that I might adopt in clinical practice as just a kind of a standard scoring so that I can compare my own cases from one to the other. But first of all, it looked at the depth of the ulcers, whether they were in the anterior stromal all the way through to deep stromal ulcers or even perforated ulcers, the size of the ulcers from small, considered as less than 3 millimeters, or medium or large, being greater than 7 millimeters, the location, peripheral, mid-peripheral or central, and whether hypopion or hyphema was present or absent. And so I guess just looking initially at the trends on this, the majority of the cases, 70% of them, were mid-stromal or deep stromal ulcers. 80% were greater than 3 millimeters, so in the medium or the large size. And then 2/3 of them were centrally located, and again 2/3 of them had a third of them had hypopion or hyphema present. And using this grading system, the average ulcer grade seen in this study was 7.8. So that's something that I might try and use kind of going forwards to help me identify and kind of be a little bit more systematic, I guess, about how I grade these ulcers. And then the authors stated the outcomes that they were going to measure. So first of all, the most important outcome was their globe retention or globe loss. They also recorded the healing time from initial presentation through to negative fluorescein staining. And then they also looked at the visual outcome assessed via the Menace response on the last visit as either absent, reduced or intact. Now, one thing they do mention a bit further on, ultimately the last visit wasn't necessarily at the very end of the healing process. It was most of the time when they'd got to negative fluorescein staining, and there may well be quite a bit of continued remodelling and improvement on that visual score over the long term. So one really important thing was looking at how the samples were collected and analysed. Basically, the clinician would put in topical proximeticaine and use a sterile swab, which was collected from the edge of the ulcer, making sure that it avoided contact with the conjunctiva, eyelid margins and the hairs. And then that was grown on agar plates and tested against the standard antibiotic disc panels. So the results, first of all, just kind of observational in terms of the patients that came in with these ulcers. The median age was 6.3 years, and brachycephalic breeds were definitely overrepresented, with 59% of the cases being brachycephalic. Of those tested for culture, 57% of them came back with a positive culture and 43% of them came back with a negative culture. Previous antibiotic usage didn't actually alter that ratio, so most of them came in with previous antibiotic usage, but it shows that even at like later stages, even once antibiotic use has been started, that it's still worth doing a culture. It doesn't stop the culture from actually, you know, working if there are bacteria there, so it's definitely worth doing. There was a total of 72 bacterial isolates in total, and there were no fungal cultures, which is fairly standard in the UK. We don't see that compared to some other areas of the world. And this graph just shows some of the results that they got. So I guess probably not that unsurprising in a melting ulcer. Just over 40% was Pseudomonas aeruginosa, but they also found a high proportion of beta hemolytic streptococcus in there. 20% of cases were that, along with coliforms, coag positive staphylococcus, and then some mixed growth and other ones there as well. Importantly, they also followed the antibiotic resistance, and the beta hemolytic streptococcus had a very different resistance profile than the Pseudomonas patients. So the Pseudomonas infected ulcers were highly sensitive to the fluoroquinolones, polymyxin B, gentamicin. Certainly that is what I traditionally would have reached for in terms of a melting ulcer. I would have gone for those ones there. And importantly, I guess they're intrinsically resistant to doxycycline, fusidic acid, amoxiclav, cephalexin, chloramphenicol there. So any cases where you're concerned about Pseudomonas, then either gentamicin or fluoroquinolone is really important there. Whereas the beta hemolytic streps, which you'll remember were about 20% of those bacterial isolates, these ones are highly sensitive to amoxiclav, cephalexin, chloramphenicol or doxycycline. So complete flip in terms of what they are sensitive to, and they are intrinsically resistant to gentamicin. Importantly, both types were intrinsically resistant to fusidic acid. Obviously that's certainly in the UK it's a common first line antibiotic there, and then the beta hemolytic streps, 67% of them were resistant to fluoroquinolones. So if you looked at all the positive cultures as a whole, as one entire group, the fluoroquinolones had the best sensitivity. So 75 to 79% of ulcers would be sensitive to fluoroquinolones. About 51% would be sensitive to chloramphenicol, and only 11% would be sensitive to fusidic acid. So another few things that came out really clearly on the results there was that when you did look at the ulcer severity grade, that was much greater in Pseudomonas associated ulcers than either the beta hemolytic streps or any of the other ulcers there. 43% of the cases received medical treatment only, whereas the rest of them were then treated surgically, and there was a choice of treatments here with the corneal conjunctival transposition, conjunctival grafts, and then a range of either A-cell, Omnigen or Biocyst grafts. And just that, well, almost 9 out of 10 healed, but certainly, well, 13%, 1 in 10 were enucleated there. And it was slightly higher proportion in those enucleated cases that were treated medically rather than surgically. So it suggests that the surgical outcome, a surgical intervention probably has a slightly better outcome there. And again, looking at the different isolates, the Pseudomonas associated ulcers were significantly more likely to result in enucleation than the other isolates. Across all the cases, the median healing time was 14 days, but the Pseudomonas associated ulcers had a longer healing time with a median of about 19 days. Again, I think this is really important in terms of identifying and giving people a sort of expectation of how long it may take to heal. Clients often really want to know exact time courses, which of course you can't give, but at least if they have some ideas from studies, then that's really helpful. 85% of the cases remained, well, no, of the patients that retained the globe, 85% remained visual, 14% had reduced vision, and 1% had lost vision. Now, this was measured by how well they responded to the menace response at their final post-op check. Now, all the eyes that had either the reduced vision or the lost vision were the ones that had undergone surgical corneal grafting. So whilst the surgical intervention appears to have a better chance of retaining the globe, it does have a significantly increased risk in reducing the vision there. Okay, so one thing I really wanted to think about was how this influences my clinical practice. So the authors state that whilst culture is the gold standard, it can be slow. And so cytology should be performed in every case, particularly because of the difference between the Pseudomonas cases and the beta hemolytic streps. And if you can identify things from cytology, then it would really help you to choose your antibiotics more carefully. If treating empirically, you probably want to be looking at doing a topical fluoroquinolone and a beta-lactam antibiotic systemically, so amoxiclav or cephalexin. But really importantly, obviously there is elements of resistance with the fluoroquinolone, so we really do want to be retaining these for the severest cases only. We could use doxycycline as well, but it is less reliable against the beta hemolytic streps than amoxiclav, but it does also have that anti-collagenase effect. So I think that's a really important one to be considering. The authors do note that this approach, whilst might be useful in a similar population, may not be appropriate in other areas, and in other areas of, particularly in different climates and things. The limitations of the study, I guess my big question is, was it a biased choice in which they sampled? Was there a retrospective study? Was it that the clinicians only recommended culturing in the more serious cases, or what was their decision-making factor there in terms of why they've cultured one sort of ulcer compared to another? Also, these are all referral cases. For me personally, I'm in first opinion practice, so that makes a big difference. And then the cytology data was not evaluated or included there, which is a shame that we don't have a paper that links the two things together, because I think that would be really, really helpful. I think knowing what to do based on cytology findings would be a major change in terms of how we approach our cases. They did talk about the fact that it didn't matter what previous vets had used as antibiotic usage, you still got good response to cultures. So any point where the ulcer starts to deteriorate is a sensible time to take a culture. So I guess for me, I found this was a useful article for my clinical work. It has changed my approach to these cases. I certainly will be quicker to use cytology, and I will be quicker to culture these ulcers, because I think it really does make a difference in terms of which antibiotic we used. I don't think I had appreciated the high frequency, 1 in 5 cases would be something like a beta hemolytic strep, and that there was such a difference in terms of bacteria and antibiotic sensitivity. And so hopefully you guys will have also found me reviewing this study helpful, and maybe it's changed your practice too. I'd really love to hear about it.